Thank you for the kind introduction. We're going to talk about pediatric bone disease today. As I've already said, I love pediatric radiology. It's just the best thing ever. And I want to share some of that passion with you. I've got a selection of cases. As I mentioned minutes ago, it's impossible for me to do everything, but hopefully you'll enjoy what we've got, and feel free to just fire questions as we go along. We've just got an hour, but enjoy the ride. So we are going to start with, essentially go from young to old. The first half is going to be to do with non-aggressive things, and then the second half will be aggressive things. And as we know, those are the terms that we like to use: aggressive and non-aggressive versus benign and malignant. So the first one, we're going to start right at the very young end of the spectrum, which would be DDH, or developmental dysplasia of the hips. It's relatively common. I scan these babies, probably have 4 or 5 patients in my personal outpatient clinics every week. And across my department, we scan 20, 30 babies a week easily. There are some risk factors that we know about. So breech babies, so they're all wrapped up and folded, and their legs are all crossed and their hips are under pressure. IUGR, which is intrauterine growth restriction. Oligohydramnios, so they haven't got enough fluid around them when they're forming, and they're all squished, and there's a strong family history as well. So we do an ultrasound for these babies, and the reason why we like ultrasound is because things aren't really ossified in the very, very early age. We can see everything very, very beautifully on ultrasound, and we don't want to do it too soon, because then you might overcall things prematurely, because there is a lot of physiological laxity in the first 4 weeks of life. And when you're ultrasounding the hips of a baby, it's not a very intuitive thing to do. You are putting the probe in the coronal view of the hip, and this is the image that you get actually. So this one is color coded, and then this is for one of my patients. So what we're looking at is a coronal view of the hips, and we get the femoral head, which is the unossified femoral head, but we can just get a tiny peek at the ossification center, which is sat just in the middle, just here. This is the acetabular roof, and we would like that to be nice and deep, because you want the femoral head to sit well seated within a deep acetabulum. So this is a color coded diagram here, and then this is a real life clinical image. And what we do is measure this thing called the alpha angle. So what do I mean by that? We draw this line here, we call this the baseline, and this is along or parallel to the ilium. So just to remind you, this is the ilium, and you want this to be really horizontal. Then you draw a line in relation to that baseline to where the ilium is. And what you're measuring is this angle here. This is the alpha angle. And you want it to be more than 60 degrees. More than 60 degrees, you are very happy, because that means the acetabulum is nice and deep. If the alpha angle is less than 60 degrees, then you should be concerned that you've got a dysplastic hip. So even eyeballing it before we've drawn the lines and got the numbers, you see here compared to here, this one is nice and deep, and the femoral head isn't going to pop out. This one is very shallow, and actually the femoral head, which is just here, is already starting to pop out. So this is abnormally shallow. It's an alpha angle of 42 degrees. So we're going to call this abnormal. So as they go through, if you scan one of these babies, you should refer them to the pediatric orthopedic people, because what they can then do is apply a Pavlik harness. And that's a good strategy to start with. And if that doesn't work, then there are more aggressive orthopedic maneuvers that they can do, things called a hip spiker. So this is as the child has got a little bit older, so they are at least 6 months by now, because we can see the ossification center on X-ray, which you can't really see at birth. And no prizes for guessing which is the abnormal hip. Clearly, this one is massively dislocated and superiorly displaced as well. So there are some funny lines that we can draw on the pediatric pelvic hip radiograph, which I didn't quite understand before I started doing this job. So I want to share with you some pearls of wisdom that I have personally picked up. Now I think I understand them, and I want you to leave this session knowing what these lines are. So femoral heads, they start to ossify 6 months or more. So this is the first line. I'm going to move this my way. Yeah. This is the first line they're going to draw. This is Hilgen-Reiner's line, and this is a horizontal line. It's this purple one that we draw through the triradiate cartilage, which is this lucent structure just here and here as well. So this is the horizontal line, and it's Hilgen-Reiner's line. Remember it because it's H, and this formed the bar H. So the next one you want to do is Perkin's line, which is perpendicular to Hilgen-Reiner's line. And this is one that you just drop along here, along the lateral aspect of the acetabulum. So if it's normal, you want your femoral head to be in the lower inner quadrant, just here. Whereas this one is clearly way out, it's in the upper outer quadrant. And also if it's normal, you want more than 50% of the femoral head to be covered by the acetabulum. Whereas if you've got more than 50%, we call it lateral uncovering, then we would call that subluxation. And the last thing on here is the acetabular index. So you draw a line here. So this one is just parallel to Hilgen-Reiner's line. And then you draw a line which is along the acetabular roof. And you want it to be less than 30 degrees. That one is normal. Because as that line tends up, then this becomes more shallow and you've got increased risk of your femoral head drifting out. So treatment-wise, orthopedics, if you think it is dodgy, then you want to do serial ultrasound scans. Because if it's something like 54 degrees and you're aiming for 60, remember, and you scan them at 6 weeks, you can scan them at 7 weeks, and actually it might normalize, and they're just a little bit what we would call immature. So you do give them a chance, but if it's way out, 42 degrees, a baby like that is not going to be able to normalize from 42 to 60. Then they need orthoreferral and a Pavlik carbonist to start with, and an osteotomy and hip spica can be considered, but this must be done under orthopedics. And just to give you a flavor as to how things progress and grow, so this was a child that we called abnormal initially. So this is the ossification center on the left-hand side. It's a bit smaller compared to the right, hey? It's a bit smaller. The acetabular roof isn't that shallow, but after the Pavlik harness was applied, the ossification centers look a bit more symmetrical now, and we've got good acetabular coverage. So this normalized with conservative management, which was a big win for this child. So moving on, this is a slightly older child now. This is a 6-year-old kid who's got some hip pain on the right-hand side. And clearly this femoral head is looking very, very abnormal compared to the contralateral side. It's very flattened, it's sclerotic, it's fragmented. In this age group, so roughly between 5 and 10 is the top end, but certainly between 4 and 8, we're going to call this Perthes disease, which is idiopathic. AVN is avascular necrosis, just to remind you. So idiopathic avascular necrosis of the femoral head. Because in the younger age group, boys more so than girls, and they get hip pain, sometimes they can limp with it, and you get these subchondral lucencies. So that's what we're seeing here. The joint space is a bit widened. So why is that? It's because the femoral head is flattened. And when it's really bad and advanced, you get sclerosis and fragmentation. So this is quite an advanced case. How these managed, again, orthopedics needs to be involved, bed rest, and also they can do surgical maneuvers, osteotomies, to try to get this femoral head well within the acetabulum so that it is well contained. But as far as you guys, chat, love it. Yes, they are coxa magna, yeah. So actually, to be fair, not much in the way of coxa magna. I mean, I could measure it. Eyeballing it, there's a bit. But yes, to answer your question, I'd say that it's a common phenomenon in advanced cases because the biomechanics are all thrown off because of the advanced flattening and sclerosis of the femoral head. Orthopedic review for sure. So we're moving up a little bit. So we're going to go for slipped upper femoral epiphysis. And quick fire in the chat now, which is the abnormal side, left or right? 50-50. Have a go. What's the worst that could happen? Left, right, left, right, left, right. What do you think? Oh, they're coming in. Love it. Very, very good. Oh, both. Oh, do you know what? I like the both because that is a point that we need to discuss. In this particular one, it is on the left-hand side, and I'm going to hopefully convince you why that is the case. We're going to learn about some lines. We're going to learn about some lines. So this thing here is something called Klein's line. The spelling is just here. And this is a line that you want to draw along the superior margin of the femoral neck. That's what we've just done here. And if it's a normal study, you want the line to go through the lateral sixth of the femoral head. Now, I know what you're thinking. It's not really that different on this film. I know. But to be fair, Klein's line is a very, very subtle finding. And I think it's something that I certainly was confused by when I first started. So I want to show it to you in its purest form. I'll be really honest. It doesn't always clinch diagnosis, but at least you'll know how to do it. So draw the line along the superior margin of the femoral neck. So if it's normal, you want the femoral head to intersect a sixth of the femoral head. Now, what happens with the SUFI, slipped upper femoral epiphysis, is that the femoral head or the femoral capital epiphysis, it slips medially and inferiorly. So it's going to go on the inside of this line. So if when you're drawing Klein's line, it doesn't intersect the lateral sixth, i.e. you don't really have much of the line going through the femoral head at all, then you should be concerned. So that's the point of Klein's line. And I use it as a supplementary tool rather than it being my go-to tool. Something that I think is much more obvious and much more helpful is looking for widening of the physis. So this is the physis here. This is the normal side. And this is the physis here on the abnormal side. And if you look at this lucency here, this is the abnormal bit compared to this thin lucency here. Normal physis, paper thin, abnormal physis widens. So that is a much more useful and a much more sensitive sign. And I use Klein's line to help me out a little bit. But actually, in reality, the first thing I ask for is a frog lateral, and look how beautifully it is depicted on the frog lateral. So normal side, we can draw out the contour of this femoral head beautifully, plumb in the joint, happy. You go along here, in fact, inferior is better. You go here, 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 uh-oh, there is a step. Definitely abnormal. And look how widened this physis is compared to this other side. The chats are coming through. Yes, Trithoran sign. Yes, yes, that is correct. That is correct. Very good. There is a chance of AVN should be avoided. If you can, it depends on the protocol of your local hospital. There are some centers where I worked where they just go for a frog lateral to start with, because as I've just showed you, it's actually much easier to pick up on the frog lateral. If you can nail it 100% on the AP, then happy days, diagnose it, call orthopedics, no need for any further views. More often than not, I would say I would ask for a frog lateral. And if you're thinking about the concern for AVN, the orthopods are going to go in and fix this anyway, if you are worried enough to then go and do a supplementary review of the frog lateral. So I wouldn't have AVN as a barrier to doing my frog lateral, because essentially I need to provide the answer, is it a SUFI, yes or no? And if it's really, really subtle, then I might resort to an MRI. But most of the time I would do a plain film, and the hospital where I work, they tend to do both AP and lateral, and we use them both together. As I said, if you can nail it on the AP, happy days, high five. I find the frog lateral more helpful, and I don't worry about the additional risk of AVN and causing further trauma by doing the frog lateral. I would rather have the answer, because the orthopods are going to go in anyway. Hope that answers that question. Risk factors, obesity, and in fact, in this particular chart, you can see there's quite a lot of soft tissue. Boys and endocrinopathy, particularly if there is thyroid acropathy, then that is a risk factor. And how do we fix these things? Orthopods quite like cannulated screw fixation. So they'll go into, something on the chat. Okay, great. I'm glad that answered the question. The orthopods will go in and do cannulated screw fixation Why? Because if this child carries on walking on this thing, then absolutely there is risk of further slip. And now we are very, very worried about AVN if it goes untreated. And they can get, or osteoarthritis of that hip as well. So it does need treatment. Something where there is a bit of discussion is whether or not we should do both hips. And I think this will very much depend on which center you work on. Some orthopods will say if they've slipped one side, they're going to slip the other side. So we should prophylactically fix the contralateral side. And the other ones will say, well, let's just see how they go. They might slip the other side, they might not. If they do, we can fix it if it happens. So with that one, I wouldn't say that there is a right or wrong, but you need to be aware that bilateral slips can happen in up to 10%. And there is a difference of opinion depending on where you work, the orthopedic consultants or doctors, their particular mode of practice. I wouldn't say that there is a definite right or wrong. And I would say that our job as radiologists is to be aware that it can happen on both sides, that you should raise that to your clinical colleagues, and then it's up to them, basically. Some more chat stuff. Actually, so let's do the first one. Is SUFI, it is a type 1 in its purest form. It doesn't actually involve the metaphysis or the epiphysis. It is purely a growth plate phenomenon. And yes, it can be removed in adulthood, but I've seen many cases in people in their 20s or 30s, whenever, and they've still got their pins in. So again, that is a spectrum depending on the orthopedic practice wherever you work. So I'd say these cases often they come to MDT, and then you can learn from your orthopedic colleagues whatever they prefer to do in the particular center where you work. So just be aware that there is a spectrum of treatment approaches. Cool. I'm loving the interaction, guys. The interaction gives me some energy, so you're going to get better quality out of me the more you give back to me. So keep it coming. Love it. So this is a snapshot, and feel free to take a picture. Personally, when I go to lectures these days, I'm just snapping all day long. Please have this for free. I think it's useful to consider them in 5-year chunks. So 0 to 5 DDH, 5 to 10 Perthes, 10 to 15 SUFI. And of course, you can get these pathologies outside of these age ranges, but it's a guide, and people tend to like things that you can have a framework for. So 0 to 5, 5 to 10, 10 to 15, just as a guide. And this is a summary of all of the things that we have just discussed. Hope that helps so far. So that's hip stuff. This one's contentious, and I want to draw your attention to some of these specific things that we really need to be vigilant for. And as a PEDS person, I deal with NAI, or in the UK, we now call it suspected physical abuse court cases, or SPA. I deal with them several times per week, and they are contentious and emotional and evocative because of all of the legal and emotional overlay that comes with these cases. I know that some of you guys will go on to do different things, but if one of these cases happens to come on your screen, I want to at least give you a few tools that you can use to say, well, this one, I'm a bit worried, or this one's probably okay. Just have some kind of framework. So this kid was 8 weeks of life and was found unresponsive at home. Unresponsive at home. So there's a few things to talk about here. First of all, there is an endotracheal tube in situ. Already, your spider sense should be tingling. Why has an 8-weeker got an endotracheal tube in? What do you think about this? And while we're there, what do you think about this? So these are posterior rib fractures, and these are both sensitive and specific for not an accidental injury. All the chat's coming through. Yeah, very good. Callus, exactly that. Exactly, very good. Loving it. To give you a bit more history with this particular child before I go on to the next image, the lungs are very abnormal, hey? So unfortunately, this was a post-mortem study for a child who was definitely abused and the parents were convicted. So it's quite a sad story, but we wanted to do a post-mortem study and it was in the name of research that was done with the permission of the parents. So you've got all of this ground glass stuff because the lungs are not aerated. And actually with this one, the endotracheal tube ended up being in the esophagus, which was fixed later. Because you can see the tip's quite low, hey? The carina is probably up here somewhere. And yes, there is a pneumothorax. So I'm ignoring the lungs, but I'm just showing you this for the purposes of the posterior rib fractures, which are both sensitive and specific. Yeah, callus of different ages. Yeah, acute and non-acute is really, really important. So thankfully, I haven't actually been called to go to court to discuss any of my skeletal survey reports, but many of my colleagues have. And what we are advised to say is that the fractures are acute or healing, acute or healing. So we don't even try to drill down and say, I think this happened 3 days ago. Roughly, you start to see signs of radiographic healing between 7 and 10 days, roughly speaking. It depends a little bit depending on which bone that you're talking about. But as a guide, we say 7 to 10 days. So if you start to see evidence of healing, then you'll say that it is at least 7 days old. But there is no way anyone is going to put words in my mouth to say that this happened on day 3 and it was by a twisting injury. We don't really use that language. We say it's acute or it's healing. Is there evidence of healing? Is there perosteorection or callus? Yes, no. So we're very, very deliberately cautious in the language that we use when we describe these things. Yes, I'm going to come to that. Really, really good question. Really, really good question. Love these questions. Excellent engagement, guys. I'm loving it. All those things are on the slides to come. So when you see this, let's pretend it was a chest X-ray from your A&E reporting pile, and the clinical question was shortness of breath, query, infection, and you see these rib fractures. Then you need to trigger the safeguarding protocol, and I'll elaborate that in a minute. When you do that, that's when you get a skeletal survey. So why am I showing these additional pictures? Because as part of a skeletal survey, we do these additional views of the chest. So the child is placed in an oblique position. And what we used to do is collimate very tightly so that you only see one bit of one side of the hemithorax. Actually, these really just amazing radiology academics, when they looked into it, they said the dose between doing very tight collimation and getting this extra bit of the chest is negligible. And actually, if you're talking about putting a child into social services care or not, that tiny 0.0000 of a millisievert, we'd rather have the information. So what we now do is open the collimations so that, yes, I'm more interested on this side with this particular view, but let me have this information for free as well, because it's all useful. So with the oblique views, we can see with greater confidence, because as radiologists, we love 2 views, or at least 2 views, that there are healing fractures here and healing fractures here. And actually on this view, you can see the callus formation really, really beautifully. So these are oblique views of the chest, and it's the whole chest, and that has evolved a little bit. Now then, what about the legs? So this is a view of the whole leg. And actually, this was done with a slightly older protocol because things have evolved. And I'm going to signpost you to some documentation from the Royal College of Radiologists, which is the UK radiology body. And the guidelines are excellent. These are written by global experts. So again, I'm going to signpost you to that. Oh, I wonder if there's an answer that's popped up. Yes, Mariah, yes. Come on, guys, I'm loving it. This is just giving me joy right now. Very good. All of the above. So this is a view of the whole lower limb. And this is a coned-in view here. And actually now this is a requirement to have coned-in, AP, and lateral views of the knees. Why? Because we can see this really beautifully. So this is a metaphyseal corner fracture, and the particular configuration of this, we call this a bucket handle tear here. This one here is a really, really nice metaphyseal corner fracture. And these are the buzzwords that we use because those types of fractures, again, are very sensitive and specific for NAI. So this little chip, which is off this corner here. So we're going to call this one an acute fracture. Do you remember? Acute healing, acute healing. That's the language that we use when we talk about NAI reporting. Now, along this leg, so this is the right leg here, this is the left leg, this is a periostal reaction. So now we're going to say healing fracture. And this, particularly along here, so this is evidence of healing of a previous metaphyseal corner fracture. And there's also a very florid periostal reaction along this tibial shaft here. So we have got fractures of different ages, acute and healing. Please remember that one. So again, this child, the parents of the child ended up being convicted. So this is what I wanted to make very clear to you. If you are the first person reporting these images, you need to contact the safeguarding team. So at least that's what we call it in the UK. Wherever you work, there will be some sort of equivalent. And in that team, there needs to be a consultant pediatrician. There needs to be a lead safeguarding nurse, because the pediatrician makes all the decisions, but the specialist nurse is so key because they liaise with the families and all those things. In fact, those are the main two people that you need to get involved. In fact, taking a step back, when you see this thing, whoever asks you to do the X-ray, call them immediately, say that you are highly, highly suspicious of a non-accidental injury, and tell them to alert the safeguarding team. Once you say those words, and particularly if they've come through the emergency department, get hold of the most senior accident and emergency doctor. And this thing, you can't log off your shift until you have got the name of the person who is supposed to be dealing with this thing, because ultimately you might be called back and it's not going to be a good enough excuse to say, I don't do peds. This thing came up on your screen, so you need to be satisfied that you have done the very best that you possibly can. What's then going to happen is that more often than not, that child will be kept in the hospital because the hospital is a safe place. And then the consultant pediatrician is then going to lead the investigations as to what happens next. Us as radiology, our job is to do a skeletal survey or facilitate the skeletal survey. So these are the guidelines. They were updated in 2017. It was reviewed in 2021. The result of that update is not quite ready for publication just yet, but certainly in this context, the 2017 guideline is more than enough, because I'm imagining that many of you guys won't end up doing sub-spec peds, but you just need to know that this document exists and go through the whole thing at least once in your life. You may not remember it, but then at least if you've read it once, because in that it tells you the particular views that you need to acquire. And it used to be 20 something views, but now it's nearly 30 very, very specific views. And there's a consent form that the parents have to sign to give their permission. They kind of have to give their permission anyway, because now they're under suspicion, or at least to say that they have acknowledged that this is the process that they need to undergo. So we do a full skeletal survey. That's where the X-ray bit is done. And then we need to do a CT of the head. And then if the CT head is abnormal, then you need to do an MRI brain and the whole spine. And that's probably the most important modification that has come out of the revised guidelines, MRI brain and an MRI spine, because you can get epidural hematomas that track down the spine as well. Do a CT. So basically, when you see a rib fracture that is suspicious, then you speak to the senior most clinician that you can get hold of. Be very, very clear about your concerns, trigger the safeguarding pathway. What will then happen is that the clinicians who are looking after that child will then open up the conversation with you as the reporting radiologist or whoever's the lead in your team. And social services, the specialist nurses. And then if at the end of all of that, there is enough suspicion, and there probably will, if you've got a metaphyseal corner fracture, to do a skeletal survey, that's when you facilitate a skeletal survey. So it's not our role to absolutely insist that a skeletal survey must be done in every single case. Our role is to accurately, or as best as we can, report the findings, notify the safeguarding team, and then the skeletal survey will almost certainly follow, but that is a joined-up conversation between all of the members of that team. And more often than not, they will come back to you to say, either, I don't know, it could be abuse, it might not be abuse, let's just do the skeletal survey anyway, just to be sure, because we're gathering evidence, or I'm really worried, there's no way this kid is going home, there are bruises on the skin, we have to do the whole thing. But to answer your question, when do we do it? Our job is to raise it, to flag it, to report the imaging that is available to us as accurate as we can, tell the people who needs to be told. Then we have a joined up discussion with all the people that I've just mentioned. And then more often than not, as a result of those conversations, then a skeletal survey will follow as part of an overall investigation. But the skeletal survey, although it's objective, it's not the only thing. Everyone needs to be interviewed. The other children in the home need to be assessed as well. Other caregivers, sometimes school teachers. It's a big deal, and it's not something that we take lightly, nor do we take independently either. So it's part of a team discussion. I hope that makes sense. And please, if you've not heard of these guidelines, at least this is the UK version, now you are aware of it, please just skim read it at least once in your life, or at the very least, skip to the bit that tells you the different views that you need. The other thing to mention is that it needs to be double reported by paediatric radiologists, those of us who have the expertise to be able to tell if it's a genuine fracture, if it's a physiological periosteal reaction rather than a pathological one, if it's a nutrient channel, and this just comes with experience and time.